All right, good morning, everyone. We're gonna get started. So my name's Adam Kraus, and I'm one of the graduating chief residents for our internal medicine pediatrics program. I'm excited to bring you our second annual MedPeds Grand Rounds. The mission of our residency program is to reduce inequities in marginalized and oppressed populations by training leaders in primary care. As such, we're extremely excited to welcome Dr. Michelle Morse, a leader in health equity and justice, to Grand Rounds today. Dr. Michelle Morse is the inaugural Chief Medical Officer and Deputy Commissioner for the Center for Health Equity and Community Wellness at the NYC Department of Health and Mental Hygiene, where she leads the agency's work in bridging public health and healthcare to reduce health inequities, guiding CHECW's place-based and cross-cutting health equity programs, and serving as a key liaison to clinicians and clinical leaders across New York City. Dr. Morse is an internal medicine and public health doctor who works to achieve health equity through global solidarity, social medicine, and anti-racism education and activism. She is a general internal medicine physician, part-time hospitalist at Kings County Hospital, co-founder of Equal Health, and assistant professor at Harvard Medical School. Dr. Morse's continued commitment to advancing health equity and justice is informed by her experience in leadership roles as Deputy Chief Medical Officer of Partners in Health, as a Soros Equality Fellow launching a global campaign against racism, and as a Robert Wood Johnson Health Policy Fellow with the Ways and Means Committee in the U.S. House of Representatives. I'm very excited for this talk today, so let's give a warm welcome to Dr. Morse.
Good morning, everyone. Can you hear me okay? All right, and folks online, wish I could see you in person, but it's really wonderful to be here. I was very honored to be invited for Grand Rounds. And even just walking here this morning, I was walking past the George Washington Carver houses and wonder what kind of connections there are between Sinai and Carver houses and the whole entire neighborhood. And I want to start, and I'll also end by inviting you all to come and visit us at the health department. We have one of our most important and most historic action centers right a few blocks away from you, the East Harlem Action Center, which is at 115th and Lex. And it's a part of our health department's place-based and race-conscious strategy around health equity. And believe it or not, just about a year and a half ago, it was the 100-year anniversary of the East Harlem Action Center. So Padmore Jean is the assistant commissioner who leads the Action Center and all of our place-based work in East Harlem, and would love to make the connection if you all are interested in bridging public health and healthcare, which is why I was hired as the inaugural chief medical officer for the health department. I found it very interesting that there was such strong support for creating the chief medical officer role in the midst of a pandemic, right? A once in a century pandemic, once in probably half a century social justice and racial equity movement. And what the health department was saying in 2021 when I started was, we need more connections between public health and healthcare delivery. And those connections should be grounded in health equity and focused in outcomes around health equity. Otherwise, the kind of frame of bridging public health and healthcare is just too big. So if we do it with a focus on advancing impact when it comes to health equity, it's a little bit more doable, but still quite challenging and keeps me up at night all the time. But it's great to be with you. I hope some of you are thinking about an MPH or thinking about a career in public health. I'd be happy to talk with you afterwards about that. But today I'm just gonna share some reflections on where we are in our current moment, the ways in which we've made progress, and also the ways in which backlash is happening when it comes to health equity and when it comes to advancing health justice. So with that, I always like to start, I'm born and raised in Philadelphia, grew up in West Philly, and went to Penn for medical school, and always like to start with a quote from W.B. Du Bois, who 125 years ago was trying to prove some of the same things that we are trying to prove today, unfortunately. And what he was doing with the Philadelphia Negro, which is probably the first ever truly expansive social epidemiological study trying to link the conditions in which people live to their health outcomes and make the case that it's not about biology or genetic or biological inferiority, but that the reason why the health outcomes for Black people in Philadelphia were worse than everyone else's was the social conditions in which they were forced to live. And so although that seems obvious to some of us, As you know, there is a very, very long-standing and cyclical conversation happening in the country right now about whether or not it's the behaviors of individuals or genetic inferiority, or if it's the social and structural conditions. So Du Bois said the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. I know you all see that on the front lines as clinicians every day, or when you walk across the street to carver houses. And there are a lot of ways in which our field and our discipline can step up and do better when it comes to actually acknowledging the social conditions and our role in changing social conditions, right? Even though we are clinicians. And then finally, this other quote, I think, helps to ground the conversation today. Keeanga-Yamahtta Taylor, who is a really amazing academic and writer and faculty at Princeton, she said, "Justice is not a natural part of the life cycle of the United States, nor is it a product of evolution. It's always the outcome of struggle." And I think the moment that we're in right now really reflects that fact as well. So with that in mind, I'm just going to speak a little bit about, what are some of the frameworks we can use to understand current health outcomes and current social conditions. I'll also talk about race-conscious strategies, and then I'll end with reparations and anti-racism action. So what do I mean by social structural context? I suspect many of you have seen a framework like this, the many layers of drivers of health outcomes. And let's admit, right, as clinicians, we spend a lot of our time in the biological and behavioral circles, and not as much time in the societal and structural circles. And that's okay, that's a part of our training. And yet, what's also important for us to acknowledge is that we have colleagues in other social science fields who can really help us understand the social structural context and act upon it in a way that's still aligned with our role as clinicians. So just encourage you to continue to reflect on our training, where some of the gaps in our training might be, and our colleagues in social sciences who can help us understand better. And I would also say that more and more commonly these days, as you're probably aware, clinicians are talking about the need to push for upstream changes and not only focus on what I like to call sick care and what many of us call sick care instead of health care. So with that in mind, let's zoom out to the world. And this data is from 2021. This is World Health Organization data. It's really looking at the mean wealth per adult globally. And it's important to acknowledge that the green, I guess green was probably chosen on purpose, but the green here really represents highest mean wealth per adult across the world, with the red, darker red, being lowest mean wealth across the world. And what we see here is that countries that were involved in colonialism, whether that's traditional or settler colonialism, have more wealth than most other countries that were the subjects of the colonial project. And what many of you, I think, are also aware of is that the health outcomes in these countries that are red or some shade of red on the map also tend to be worse. It's not saying that that's the only reason that health is worse, but it's certainly connected. And I think it's very important for us to acknowledge, yes, we are a country on this global map. And in the pandemic in particular, we saw how wealth inequity and vaccine inequity played out around the world along these same exact lines. Similar, let's just come back to the United States for a second and also acknowledge how unique we are when it comes to wealthy democracies. So we are an outlier yet again in both the amount of health expenditure, but also the lack of relationship between that health expenditure and life expectancy. We have some of the lowest life expectancy of wealthy democracies. And unfortunately, as you know, it got significantly worse during the pandemic. But worth acknowledging that our resources and our resource decisions on how we spend our healthcare dollars is not getting us the bang for our buck. And there are a lot of reasons we could explain that by. All right, so then let's zoom in one more time here to New York City specifically, since this is where you all are operating day to day and dealing with all of the challenges that come with, unfortunately, a lot of social inequity in this city and in our country. What I want to highlight here is not just what you already know, that the rate of premature mortality in New York City went up significantly during the first year in particular of the pandemic. You already know that, you lived it. you experienced it as either students or residents or faculty. And I want to also underline that premature death for us in the health department is defined as a death before age 65. And that's because, as former Commissioner Mary Bassett often would say, everyone can agree that a death before age 65 is preventable, is something that shouldn't happen in a country as wealthy and well-resourced as ours. But what is often forgotten is that long before the COVID pandemic, there was this slow burning crisis of racial inequity and premature mortality, such that Black people in New York City specifically had the highest rates of premature mortality for many decades, long before the COVID pandemic. That got worse, obviously, during the pandemic, but that inequity has been there, and we've been trying our best to call attention to it because it means that something's not right. Now, what is the cause of that something not being right, I think, is where we often get stuck. And so let's, again, go back to wealth. The reason I'm honing in on wealth is because there is a lot of information around income and how income relates to health and health outcomes. There is much, much less information about the relationship between wealth and health outcomes. And there is a lot of distinction, there are a lot of differences, and there's some preliminary research that you see on the left suggesting that wealth is associated with better medical care, living in a neighborhood with fewer environmental hazards, higher quality insurance. These are things that are not rocket science and probably not surprising to you, and that higher levels of debt are unfortunately associated with higher rates of anxiety and stress, a higher likelihood of foregoing preventive care and even emergency care, and poorer socio-emotional well-being for children. And what you see on the right is data from the Survey of Consumer Finances, which is a national survey conducted by the Federal Reserve Bank that really looks at the relationship between wealth and many other demographic variables. And on average, what we know from the Survey of Consumer Finances is that white people in the United States have about 8 to 10 times more wealth than the average Black or Hispanic family. And again, these things need more research. So all the researchers or future researchers or future sociologists or future social epidemiologists in the audience, this is an area of inquiry I would encourage you to spend some time on and spend some time developing. So again, let's go back to first principles. How do we explain these inequities? How do we explain the high rate of premature mortality for Black New Yorkers and the high rate of wealth inequity and the relationship between those things and health outcomes? So critical race theory is a theory that has become very highly politicized, but actually is a theory that was developed by legal scholars in the 1970s and 1980s as a result of trying to explain why, after the civil rights movement, they were witnessing and seeing such significant backlash, backpedaling, and loss of gains from a policy perspective after the civil rights movement. They were seeing in the 70s and 80s a very significant kind of backpedaling and loss of ground when it came to civil rights and racial justice in this country. And so they created this theory really based on their observations, trying to explain, well, why is that happening? Why is this backlash happening? One of the tenets of critical race theory that is most relevant to us in medicine and public health is the social construction of race. And the social construction of race is that adage that you're hearing everywhere and seeing everywhere, right? Race is a social construct or a political construct, not a biological or genetic one. And the Human Genome Project has proven over and over again, right, that there's more genetic diversity within what we call races than between races. Again, really upending this idea that there's any real stable relationship between what we call race and genetics. So now apply critical race theory to public health, because we are public health and healthcare people. And this field was really defined in many ways by Collins, Irambua, and Chandra Ford. I would encourage you to read some of their research. They developed this theory of public health critical race praxis over 2 decades ago. It is incredibly helpful, particularly for those of you in the research and evaluation world. It is a series of steps and frameworks to use when you're developing a research question, when you're developing a research project or an evaluation project, that helps you to think about your own identity and perspective, how that might be influencing the research questions you're asking, and also is a very methodical, stepwise approach to try to reform, revise, or transform your research question in a way that's anti-racist and that advances and acknowledges the racial dynamics in our country. So part of what they really describe as a key piece of praxis Praxis being this beautiful continuous cycle of education and action. What they say in this praxis is that we have to continuously generate knowledge from outside our historic or core knowledge base of our discipline. And why is that? Well, it's because of what Du Bois was doing 125 years ago, right? If we look at the roots of our discipline, there is profound structural racism influencing the ways in which we understood health outcomes, health care, et cetera. So that means we have to continuously build this new knowledge base that is anti-racist, that acknowledges the history of racism in our field and actually counteracts it. So that's for you guys to do. So let's just get into some practical examples. I've spent enough time on theory, and I am gonna make sure that we have about 15 minutes or so at the end for questions. So I hope you're jotting down your questions and your thoughts and your reflections so that we can have some dialogue at the end. But let's talk about race-conscious strategies. Race consciousness is another tenet of public health critical race praxis as well. So let's go back to what was a very, very difficult time in this city. Raise your hand if you were here practicing in May of 2020. Yeah, okay. And raise your hand if you were a medical student in May of 2020. Okay, great. So you all remember this time very well. And whether you were here in New York City or not, this trend pretty much held across the whole entire country. So what you see here is in this flashback to 4 years ago, is really looking at the impact of COVID on cases, hospitalizations, and deaths by race ethnicity here in New York City. And what we see, and you can still access all of this data if you want to take a deep dive and look back, which is something we do often in public health. But what we see here, of course, in terms of both hospitalizations, cases, and confirmed and probable deaths, is that there was a disproportionate impact. I know that's not news, but just a reminder of what we have been through in these recent 4 years since the start of the pandemic, which again is truly a once-in-a-century pandemic. So the disproportionate impact on Black and Hispanic New Yorkers was very obvious and very clear from pretty early on. Some of you may be reading Uche Blackstock's recently published book, Legacy, that's kind of, and she just has several chapters describing her experience as a frontline clinician, really seeing how this played out in real life as a clinician in Crown Heights. And not long after that snapshot from May of 2020, about a year later, so this data is from June of 2021, so that's about 6 months into the vaccination campaign here in New York City, what we saw, unfortunately, was the very people who had had the worst impact, the most unfair, avoidable, and unjust impact from COVID were the same people who had the lowest vaccination rates. And there were a lot of theories explaining why this was the case. Lots of people said, oh, well, those folks just don't trust the vaccine, or, Black and Latino people, they're just not interested. There were a lot of theories floating around, if you remember, this time. And what we in public health here in New York City's health department really tried to do was make it clear that actually there are a lot of other upstream reasons why Black and Hispanic people in New York City may have the lower vaccination rates. You remember some of the early days of the vaccination campaign where there were examples of people not from that neighborhood coming to get the vaccine or quote unquote skipping the line. There was also a lot of publicity around the lack of trustworthiness, frankly, of the public health system and the healthcare system, and the bad experiences that many Black and Hispanic and other people of color had in the public health system here in New York City, amongst many other things, right? Even though the vaccine was free. Was there a vaccination site in your neighborhood? Was it easily accessible? Was the information being shared in your language? Did you have a trusted healthcare provider you could talk to and ask your questions about the vaccine safety without being judged? So as you know, I'm hopefully preaching to the choir here, there are a lot of reasons that are not the fault of Black or Hispanic people for this low vaccination rate. And so that's the analysis that we used at the New York City Health Department to say, so this means we actually need to work harder, and we need to focus our resources and accessibility and language and outreach in the neighborhoods that have large numbers of Black and Hispanic people, and we need to actually not be the people with the big scary health department jackets and t-shirts going out saying, get your vaccine, get your vaccine. We're not the trusted messenger in many communities, and there's a long, long history of reasons for that. But we needed to acknowledge that and then actually, again, be race conscious and act differently, right? We can't just do the same vaccine delivery program in every neighborhood. It actually needs to fit what that community wants to hear from us and needs to hear from us. I also want to acknowledge a very important race-conscious strategy that your state health department implemented at the beginning of the time in which molnupiravir and Paxlovid became available. And if you remember that time, there was very, very little access because there was such a limited supply of those two medications. But what the state health department actually said was, we see this data showing this disproportionate impact on Black and Latinx people across New York State. For social reasons, not for biological reasons, for social reasons, they should be prioritized for treatment actually during this time period where we have a limited supply because of the high rate of hospitalization and death. And so that was a policy that was on the books in the New York State Health Department and was used by some clinicians, maybe not all, but used by some clinicians. Now, the State Health Department was sued for this policy, even though it is grounded in data and grounded in race consciousness and grounded in the principles of health equity. So again, just highlighting some examples, real life examples of race consciousness in policy and health policy. But so at the New York City Health Department, we said we cannot just let these vaccination rates happen, right? We need to actually step up and acknowledge the ways in which public health has historically excluded Black and Latinx people and they have had bad experiences, and we need to resource the existing infrastructure in those communities via community-based organizations and community health workers to make sure that the message is actually getting to those communities in a way that they want to receive it, in a way that makes sense to them, in the language that they want, in the location that they want. So that's how we developed and launched the Public Health Corps in the summer of 2021. And it was announced officially in September 2021. There were over 100 million city tax dollars put towards this program in the first 2 years of the program to address exactly that trend that I just showed you. And we had a lot of success. There were a number of different policies that went into place at the same time, but we did over time, over those first 2 years of the Public Health Corps program, we were able to get not only rates of vaccination in public housing, just referencing the Carver houses across the street and wondering what kind of relationship Sinai can develop or has with Carver as an example of the way that we can bridge public health and healthcare and do the kinds of community engagement work that our communities need us to. But we were able to get to over 90% vaccination rate for residents in NYCHA through, again, funding community-based organizations, training and deploying community health workers across the city in the neighborhoods where we know we needed and owed additional resources and focus. And we were also able to get the vaccination rate significantly higher in what we call the TREE neighborhoods. These are the Task Force on Racial Inclusion and Equity neighborhoods. These are the neighborhoods that were designated across the city as the neighborhoods that had an unfair and disproportionate impact from COVID and also had suffered, unfortunately, in most cases, decades of redlining, decades of disinvestment, decades of many other social policies that left those communities particularly marginalized and vulnerable to the impacts of COVID. So we were very proud of some of these successes and very proud, of course, to have been able to implement a race-conscious, place-based program during what was one of the most wild, I would say, pandemics of health inequity that I've seen in a while. And these are, you can find this on our website. This is really just a snapshot of the first couple years of work and what we were able to do across 75 zip codes, 35 community partners. We engage with over 700,000 community members, over 230,000 referrals for vaccination, and almost 2,000 trainings that we held in the first 2 years of the Public Health Corps program. We at the Public Health Department in New York City run one branch of Public Health Corps, and then Health and Hospitals actually runs another branch that has community health workers in their primary care clinics. So with that in mind, certainly, we still have a lot of challenges, as you know, when it comes to COVID, and every respiratory viral season since those first couple of seasons has been a big challenge because a lot of the federal funding for these programs have dried up and gone away. The public health emergency ended, so the vaccine is now commercialized and no longer publicly freely available, amongst many other things. So it's not that the challenge is over, but that was our response. Again, that was both race conscious and place-based to those first 2 years of the emergency. So let's talk about an even more clinically focused example. I know many of you are very familiar with the work around changing the way that we calculate EGFR. If you remember, or I was in high school, graduating from high school in 1999 when this came out, but this article in the Annals of Internal Medicine was a groundbreaking article. Of course, this was the first time that there was actually a way of trying to better estimate GFR. As you know, it can be measured or estimated, and this equation was really created to be a shortcut for clinicians, right? To actually get a better estimate, a more accurate estimate of GFR rather than measuring it directly, which is extremely time-intensive, labor-intensive, et cetera. So when this article came out, it was a groundbreaking article in the field, right? And certainly important for anyone in any field of medicine. And at the same time, there were a lot of flaws in the way that this study was conducted. So if you remember correctly, the MDRD equation, again, published in 1999, had a Black race modifier multiplied by 1.21, quote unquote, if Black. And then the more updated version, the CKD-EPI equation that was published in 2009, which is probably, at this point, prior to the changes, was probably the most common of the equations being used at most labs across the country, had a Black race modifier multiplied by 1.159 if Black. And we can have more discussion about the female the female gender modifier at some point if you're interested. But these were the equations. These were considered the gold standard. They were probably used here at Mount Sinai, I would assume. And at the same time, when you take a look back at that original study and you look at the methods and you look at the people who were included in that study, you'll see that only 197 people in that original study in 1999 were Black. And Black race was assigned by the study personnel. It was not self-identified race. So it's not exactly clear what was actually being measured. And then what this kind of, inclusion of about 200 or so Black people became the gold standard for millions and millions of Black people across the world, not even just in the US, but across the world. So very challenging to really rectify how, such a small group of people ended up becoming the standard for the whole nation. Now, there have been studies since that have looked at this relationship and found some similar trends. But again, it's the implementation of this in day-to-day practice that is really the challenge, right? I often give the example of Barack Obama, who is biracial. But would you use the Black race modifier in calculating Barack Obama's EGFR? Would that be the right thing to do? Would that be the wrong thing to do? Does he count as Black biologically? There are a lot of questions, right, when you think about how this gets applied in clinical practice. And then the other piece that's worth mentioning is that in that original study in 1999, they had to explain, well, why this Black race modifier? Why is that part of the equation? Why does that improve kind of the quote unquote fit of the regression analysis? Why does that improve the accuracy? And their explanation, the researchers' explanation at the time, was they cited these 3 studies and said that our theory is that the reason we need to include this Black race modifier, why might the correlation between measured and estimated EGFR be slightly different for Black people, quote unquote Black people? We think it's because there may be greater muscle mass amongst Black people than white people, which of course is absolutely unfounded. It goes back to 200 years of white male physicians in the 1800s trying to justify slavery by saying that Black people are just more well suited to the conditions of enslavement than other people are. And they said, one of the reasons was that Black people had more muscle mass. And these 3 studies, if you look at them, are number one, outdated. They are not methodologically rigorous, and they again have essentially been disproven. So this is a very much very disproven and also very historic association that is completely unfounded. And again, is an example of how our field in medicine has to put the mirror up as often as we can and remember that these are the kinds of claims that were a part of mainstream medicine for hundreds of years. In fact, as recently as 1999 when this study came out. So this again, encourages all of us to ask ourselves more questions about the assumptions that we use in everyday clinical practice. So what's the bottom line on this? Well, you guys already know, right? This got changed after much struggle, and students and trainees really on the front lines of that struggle pushing for the change. But ultimately, what's clear is that having that Black race modifier is trended towards worsening the racial inequities in chronic kidney disease and end-stage renal disease. It certainly contributed towards it, and contributed towards the fact that the prevalence of CKD amongst Black people was lower, but then the rate of end-stage renal disease was significantly higher. This Black race modifier made Black people, quote unquote, Black people's kidney function look healthier at the same measured rate as other people, as white people. And that, of course, created some of the significant inequities in both chronic kidney disease and transplantation that we saw. So I had the honor of being on the Ways and Means Committee as a fellow in 2019 to 2021. And this was one of the projects that we worked on. The chairman of the committee sent letters to every professional society that had a widely used algorithm that misused race in some way, that conflated it with biology and had the impact of worsening racial inequities. And the chairman said, you know, we'd like you to re-examine the way that you're using race in this clinical algorithm and come up with something better. And a lot of professional societies said, yes, we'll take that on. Some of them did not. But the American Society of Nephrology said, all right, we're going to create a task force and we are going to re-examine this practice and figure out, you know, does the benefit outweigh the risk of using the Black race modifier in EGFR calculation? I also am very proud of the work of our Global Campaign Against Racism, the organization I co-founded, Equal Health. We are in our 7th year of this campaign. Some of you are involved in it. And it was very exciting that in 2020, the summer of 2020, Vanderbilt University Medical Center announced that they were changing their algorithm. And that was shocking because they were the last medical school to desegregate in the country. And they're, of course, in Nashville, Tennessee, not exactly a place that's known for progress on racial justice in a lot of ways. But this chapter of the Campaign Against Racism had been working for 2 years leading up to this announcement to try to get this change to happen. And many other institutions across the country also made these changes because, again, of the organizing of you all, of trainees and medical students all across the country, institution by institution, saying that we've got to re-examine this. This is not good science. And then, as you know, a new equation was published in the New England Journal in the fall of 2021 that doesn't use a Black race modifier, that is still considered quite accurate and helpful, and, you know, doesn't have all of the same challenges that we saw with using the Black race modifier in the original 1999 or 2009 studies. I also want to just highlight that Mount Sinai is a member of CIRCA. So when I started my role as the chief medical officer here in the New York City Health Department, one of the things that I wanted to do was work with hospitals all across the city to accelerate some of the de-implementation of racist algorithms across health systems. Part of the reason for that was if every health system just did it on their own, of course, there's time lost, there's learning lost, there's collaboration lost. And the idea behind our coalition to end racism in clinical algorithms was, let's use this forum as a way to both raise consciousness about the problems with racism in clinical algorithms, as well as accelerate the changes across health systems in New York City. Because as you know, it often takes an average of 10 years to go from mainstream research to changes in clinical practice at scale. And of course, for this, we do not have 10 years to just kind of wait for it to slowly diffuse and for changes to happen. So this needed to be accelerated. That's what the coalition's work was for its first 2 years. And the goals of the coalition were, number one, to change the algorithm, right? We asked the health systems to focus on either EGFR, pulmonary function tests, or vaginal birth after cesarean section, all algorithms that have that misuse race in a way that's been widely studied, publicized, and you know, where concern has been raised. The second was to measure the impact of changing those algorithms on racial inequities and health outcomes. And then the third was to develop a patient engagement plan to make sure that patients whose care had been harmed or delayed by the use of the race modifier actually got the care that they needed. So this was really fun, in fact, even though anti-racism work isn't always fun. These are the members of the coalition. And we, again, have been really thankful that Sinai has been involved in the coalition from the beginning. We did put out an inaugural report of the first year of the coalition's work. And then we recently got a grant from the Robert Wood Johnson Foundation, actually, to study the first 2 years of the work of the coalition to show what the impact was. But in our inaugural report, just a couple things I'll share. Some of the barriers to changes that the health systems told us about, who were members of the coalition, was that changing the habits of late career providers, this is not a knock, this is just a reality, was a big challenge to making these changes at scale. And that changing the algorithms in very large systems like Sinai's, right? Large, complex health systems requires buy-in of tons of stakeholders, right? It's the lab, it's also, the department chairs, it's the, EMR people and the people who are managing, all of the changes in the EMR. So there are lots of layers to making these changes in complex health systems. But the things that helped to make the changes possible was strong support of senior leadership, that trainees leading the charge was very important, that having lots of different channels for kind of education and consciousness raising was very helpful, and then having multidisciplinary teams also made a big difference. So these, again, are just the preliminary findings. This fall, we'll have another big report coming out describing the first 2 years and the impact of our work. But I did want to take a second, and I'm only going to speak for another 10 minutes or so and then open it up for questions, but I did want to take a second to hone in on vaginal birth after cesarean section. We've been focusing a lot on birth equity at the New York City Health Department because of the 9 times higher rate of death for Black women in New York City during and after pregnancy compared to white women in the city. And the reason I want to highlight this one is kind of the same thing happened as what I described in EGFR in many ways, right? Black race and Latinx ethnicity were included in this algorithm because what they were seeing was that there were, unfortunately, kind of higher rates of complications for Black and Latinx women. Unfortunately, the algorithm then baked in that inequity as an assumption that that would just always be the case, instead of actually saying, okay, our observation that the complication rates are higher for Black and Latinx women is a product of our, health inequities, social policies, and health policies, not something that's natural, normal, or needs to be the case for forever. So in fact, this algorithm was just assuming that that was normal. And it's not, right? And so the changes that were made to this algorithm were to say, actually, we need to take those factors out. What they put in instead, believe it or not, was controlled high blood pressure. And that's something we can do something about, right? So if you had controlled high blood pressure, your chances of complications from a VBAC were significantly lower. And so that's what the clinicians needed to focus on, right? Was controlling the blood pressure, not saying, oh, well, Black and Latinx people just have higher complication rates, nothing I can do about that. So I think this is another great example of how our reflex in day-to-day practice is often built on racist assumptions that we need to continuously challenge ourselves to question. And I think you guys are doing that here at Sinai as well because of your participation in the coalition. I'm not going to get into some of the specifics there, but I think they're going to share these slides with you guys and follow up. Final quick example. This was work that I did at Brigham and Women's Hospital for a long time before coming here to New York City. In 2017, I was asked to co-chair our Department of Medicine's Health Equity Committee. Again, because residents and medical students were saying, Brigham and Women's, you guys got to do better. Like, where is the anti-racism in our hospital? And so what we did on that Health Equity Committee was we started to look at and observe some of the ways in which we were not actually living up to our values when it comes to health equity and access. And one of the areas that we decided to focus on was heart failure care, because the most common diagnosis for anyone admitted in our emergency room was heart failure, actually. There was a lot of attention from CMS, Centers for Medicare and Medicaid Services, on heart failure readmission and rates of racial inequities in heart failure readmission. And the observation of our house staff was, it seems like it's mostly white patients that end up on the cardiology service, whereas most of the Black and brown patients end up on the general medicine service. And I'm a general medicine hospitalist and also trained at Brigham. And so I thought, oh yeah, that is absolutely true. That is an observation that we saw. And what we also knew was, because of some of the work that the cardiologists at Brigham had been doing at the time, we also knew that there was a higher rate of readmission for patients with heart failure on general medicine, and there was a lower rate of follow-up in the cardiology clinic. So we said, well, let's figure out, does the data actually bear out this observation? And of course, what we found was that it did. So we did a 10-year retrospective review of all the heart failure admissions from our emergency department for anyone with the primary diagnosis of heart failure. This is over 3,000 unique patients over the course of that 10-year analysis. And what we found really was that that was the case. So about 2/3 of white patients with heart failure ended up on cardiology. About half of Black and Latinx patients ended up on cardiology. And we also reproduced the finding that had already existed, that there was a lower rate of readmission for heart failure for the patients on cardiology, and there was a higher rate of cardiology clinic follow-up for the patients on the cardiology service. And what we also, this perhaps most important, one of the many important findings was that the readmission rate for heart failure for patients on the cardiology service was the same across races. There was actually no significant difference between races for patients with heart failure admitted to the cardiology service. And part of that was, of course, because on our cardiology service, we had additional pharmacists, we had nurses making phone calls on discharge, we had a much more, I would say, rigorous heart failure protocol for patients admitted. But then what we said was, well, we need to figure out, why is this happening? How come the Black patients and the Latinx patients are ending up on general medicine and the white patients are ending up on cardiology? We did a survey in the emergency department to ask the clinicians how they were making these decisions, these triage decisions. And what we found was that they said, actually, the clinicians in the emergency room said that white patients were more likely to ask to go to the cardiology service, and that request influenced where they sent the patient. And so it's another example of white privilege, frankly, right? And it's also an example of patient empowerment. But there are many reasons why we had to say, oh, okay, well, that's probably not the best way to determine who goes to cardiology and who goes to general medicine. And it's important to acknowledge that patients feel this discrimination. And I don't know if you guys have looked at this at Sinai, but study after study nationally has shown that patients of color report discrimination and report that impacts their level of trust in the institution where they're getting their care. So part of what we did, and I'm presenting this also on behalf of a massive team of people at Brigham and Women's that are still working on this, including one of my close colleagues, Dr. Bram Wispelwey. We developed both an anti-racist agenda for medicine and published it in the Boston Review. And then we, within that article, described a model or a framework called the Healing Arc model. It borrows from the work of Sandy Darity and Kirsten Mullen, who developed a framework around repair, acknowledgement, redress, and closure being the key steps in this repair approach. And the Healing Arc approach is really about acknowledging, number one, when you find these examples of institutional racism, acknowledging that they exist, publish it, be honest about it, take responsibility for it, don't try to hide it, right? This is the reality, and this is what patients of color are experiencing every day. And then do something about it. Redress is the second step. You have to actually change it, right? It's great to study it, but then you have to do something about it. And then the third piece is closure, ensuring that the community that was impacted by this policy or these decisions or this trend actually themselves can say, actually, we think that this has been adequately addressed. We feel comfortable coming back to this hospital. And so how did we do this at Brigham? We implemented a first of its kind best practice alert. In fact, to our knowledge, this is the first time a best practice alert has been used to actually change a health inequity. And that is really sad, frankly, right? That we use best practice alerts for all kinds of things, and we could use them for changing behavior of clinicians to advance health equity, and we don't. So what we did was we actually created a best practice alert in Epic at our system. And the alert comes up if a Black or Latinx patient in the emergency room is admitted with heart failure and they're sent to the general medicine service. A best practice alert comes up and says, this patient is from a racial or ethnic group with historically inequitable access to the cardiology service. Consider changing admission to cardiology unless extreme census or overriding clinical reasons for general medicine. So we're going to be hopefully soon in the next year or so publishing the results of implementing this best practice alert. It went into implementation in 2022. And just spoiler alert, it had a very significant impact on where patients were sent. We experienced a really tremendous backlash against this work. There were over 20 articles in right-wing news outlets saying that we were racist for doing this, that it's unfair to white patients, that we're wrong, et cetera, et cetera. Again, and this was really all in like white, white nationalists and right-wing news outlets, unfortunately. At the same time, we got a lot of support from the Global Campaign Against Racism and many of our colleagues who reached out and said, keep going, right? If your enemies are white supremacist and white nationalist groups, you're probably doing something right. And this work needs to continue. And you should continuously push, right? Because what they were trying to do was a misinformation, disinformation campaign. They were trying to start from the wrong place, right? Instead of acknowledging that the current system was unfair to Black and Hispanic patients, they were trying to say that it was unfair to white patients. So completely erased the history and the study and all the rigor that we put into proving that the current system was actually unfair to Black and Hispanic patients. So let's get into my final couple of slides, and I'll just be closing out in a couple of minutes, so hopefully you guys have some questions. Dr. Bassett and Sandro Galea, two beacons in public health that you're probably familiar with, published an article in the New England Journal a couple of years ago describing the positive health impacts of reparations, and they were defining reparations as payment for enslavement to descendants of enslaved people in the United States. And the idea here again was making that connection between wealth and health. And then in addition to that, the trend that happened, as you probably remember, after the murder of George Floyd, there was an exponential increase in the number of resolutions declaring racism a public health crisis in the country, including here in New York City. So if you haven't read the New York City Declaration of Racism as a Public Health Crisis, it's only 3 pages. It was passed by the Board of Health here in New York City in the fall of 2021. And these are a couple of the statements. Whereas settler colonialism, indigenous genocide, and enslavement of Africans are part of the history of our nation, and whereas these original injustices have been without comprehensive restitution or redress, whereas racism is a race-explicit system, anti-racism requires race-explicit strategies, and the work of undoing racism is grounded in love as well as science and civic duty. This love is not sentimental, rather it's what James Baldwin called the tough and universal sense of quest and daring and growth. So these are just a few of the statements in your city's resolution. And it has a series of 8 actions that are required of the New York City Health Department and all of our partners to really advance anti-racism and public health. So definitely encourage you to take a look at it. It's an example, I would say, of strong anti-racist health policy work. And then just another acknowledgement of what we tried to do in our publication was to say, even if we implemented healing arc models all across the country for examples of institutional racism in healthcare, at the same time, there still needs to be a federal, a national redress for the impacts, the ongoing impacts of enslavement on health and health outcomes across this country. And that even if reparations were paid today, for example, that wouldn't erase institutional racism all across healthcare institutions in the country. So these things are connected and need to be part of a multi-layer policy prescription to end racial health inequities. And then the final thing I'll share is, especially because it's been more than 20 years since Unequal Treatment was published, and unfortunately there hasn't been a whole lot of change on the inequities, the racial inequities that were described in this landmark study. At the same time, what we did an analysis just looking at what would have happened in terms of COVID transmission in this country if there had been an elimination of the racial wealth gap and reparations had been paid prior to the COVID pandemic starting. And our model estimated that COVID transmission would have been 30 to 68% lower than it was if there had not been such a significant wealth inequity. The reason for that, well, when you have wealth, you can buy masks. You don't necessarily live in crowded housing, right? You don't necessarily have to take, unsafe transportation. You also have the possibility of getting access to healthcare. And there are a number of other reasons why wealth is protective in general, for your health and in general for you as a person, but also specifically in a pandemic where so many people were stuck in positions where they could not protect themselves. So I wanted to close with that and also just say thank you for inviting me and really look forward to the questions or comments that you guys might have, and I'll just open it up. Well, first of all, thank you so much. This is such an amazing presentation. I actually had a question about one of the slides from the beginning. I think it was the one on colonialism and wealth inequality. Have there been any data or studies comparing the health outcomes of Black people in America and migrants with like people in the global South? That is a great question. I'm familiar with some studies looking at the racial wealth gap in the global South compared to the racial wealth gap here in the United States. But looking specifically at the differences in health outcomes is a great question. There's, of course, kind of, if you look at most countries' profiles, you can see like what's the life expectancy, et cetera. And some places you can see that stratified by race. But I'm not familiar with anything recent. The HIV era, there was a lot of work looking at that, like looking at HIV outcomes across races, across countries, but I'm not familiar with anything like recent or during the pandemic really looking at that.
I was thinking about the race-based, race-conscious approaches that the health department has had around COVID, and now the resurgence of mpox.
Yeah.
And disparities in vaccination around mpox. And I'm curious if the health department has had intentional strategies around that and vaccination sensors.
That's right. We actually did something very similar for mpox that we did for COVID, funding community-based organizations that, again, were trusted messengers to do both the outreach, education, and making the vaccination appointments. I would say there was less attention in some ways, less funding, less resourcing. So we still had a lot of challenges with very similar inequities during mpox and have a rising number of cases of mpox right now, in fact. And so we do still see those same racial vaccination inequities for mpox, unfortunately, despite some of our efforts, resourcing community-based organizations and outreach. And I think it's really, again, for the same reasons that we had the challenge in COVID, unfortunately. But I'm glad you raised it. Yeah.
We have a question from online
Mhm.
for us. So the statement of question, what is your opinion of using social determinants for risk calculating tools that prevent CVD risk prediction tool that includes heart failure, removed race, and instead uses zip code as a surrogate for socioeconomic status? Prevent does reduce the overestimation in some, but there has not been great uptake to replace the 2013 one. Do you endorse Prevent, and what will it take to bring attention to stop using older race-based screening tools?
That's a lot.
I should have broken up.
Great questions. Those are great questions. I would say there is a lot of work, as you all know, happening around trying to screen for social needs, for health-related social needs, whether that's screening for needs around food or needs around transportation or housing or other areas, mental health included. I think that work is important at an individual level, right? We in healthcare should both know about and support and resource patients who have specific social needs, whether it's related to their health outcomes or not. That's just a right, in my opinion, right, to be able to have access to housing, et cetera. So I don't think that that's bad. I think what is bad is that sometimes what I see is that people start to say that addressing the social determinants of health as like, and screening for social needs is a technocratic kind of fix for structural racism. I think that is not a leap that we can take, right? That's like a bit gone too far. And we're also not, I would say, raising enough awareness about the patterns of health-related social needs, right? This is still a structural issue. And even though I think it's important for clinicians and social workers, case managers, others to screen for social needs, and we should be addressing them, that doesn't really fix the structural problem. Now, there is also a lot of debate, of course, in the health policy world about risk adjustment or kind of risk stratification. I would say in general, when that happens, it doesn't really also fix the structural problem. And what most people say is that sometimes if we do risk adjustment, okay, it might improve the resourcing of some institutions or clinics that see more people of color or more people with social needs, and yet it's unfair in some ways because it sets a lower bar. And so I don't think it's the right way. I don't think it's an anti-racist approach to addressing social needs. I do think screening is important, and screening and referring is important. And then for the ASCBD thing, I think it's a win that they took race out. I think it's important to acknowledge yet again that it's not normal for these racial differences in risk. And we have to find other objective measures to include in the risk stratification rather than assuming it's normal for Black people to have a different risk. So now implementation of that is a challenge. I will say that our next iteration of CIRCA, which we just launched this last month, will have a fourth area of focus, which is on race kind of essentialism in hypertension treatment. The JNC 8 guidelines that say use this category of antihypertensives for Black people and this category for others is a part of what we're going to focus on in this next iteration. And within that, implementation and use of the ASCVD calculator is potentially going to be a part of what we recommend. So I do think that that change is very important as well.
As a member of Sinai, I think we are like so for sure. Like I don't think we have even gotten close to where we need to be, and I think we have a lot of work for that in the department of health. Like what accountability metrics are being discussed the whole health system, like accountable for actually failing these health measures because it's killing them.
Mm-hmm.
That's my first part, and then the second part is a lot of us I think are struggling, especially in this city with health insurance and like getting our like patients where they need to be because of where they can go and who gets who, and it's basically just a giant nightmare.
Mm-hmm.
And it's really, especially with like mental health crisis. So I guess it's like, how much can we actually fix in this like system? Like, have we reached out to this? And like, we need to start looking at like a different way to do this because I think for us, it's like I always feel like putting body work in this hospital. We're not fixing that issue.
Yeah. Two great questions. I think the question about accountability is a big one. And I think part of the way accountability works is consciousness raising and raising awareness, right, about progress or lack of progress. Because it's also important to acknowledge when lack of progress happens, well, why? What were the barriers? And that's part of the reason we did our first report, really saying these are the facilitators, these are the barriers. I think another piece of accountability is just the evaluations that we're doing of the coalition, right? And they really are institution by institution and then summarizing like these are the things that helped, these are the things that didn't help, and then these are the steps that need to be taken. When it comes to like actual official kind of more enforcement oriented actions or regulatory actions for accountability, the New York City Health Department doesn't have that authority. We actually are regulated, the healthcare institutions are regulated by the state health department. So they're the ones who have more regulatory and enforcement authority on accountability for this. So I think there's always a great opportunity to advocate at the state level for some of these, for both like transparency on who's made the changes as well as enforcement. And there's just recently a rule that was put out by the federal government, by CMS, the Office of Civil Rights, within the Section 1557 of the ACA, which establishes the Office of Civil Rights within the ACA and those entitlements, created a new rule that basically says you cannot discriminate through algorithms based on race, sex, gender, et cetera, et cetera. And I think there will hopefully be even more kind of action related to that new regulatory description of clinical algorithms being a potential source of inequity. And then for the second one, it always feels, the work on the front lines always feels like a drop in the bucket. It really does, right? It's like both so important because that is where we actually see whether or not our systems are working and who they're working for and who they're not working for. And at the same time, it can be so challenging because it feels working on the front lines can feel so far removed from the policy changes that need to happen. And I would say when it comes to health insurance enrollment, we have so many challenges, and yet compared to many other states, we're doing really well. Even with the end of the public health emergency and everyone needing to kind of reapply for Medicaid, the state overall is doing pretty well compared to other states in terms of re-enrolling people in insurance. We also are one of only 2 states in the country that have an essential plan, which is basically kind of a state-funded health insurance product that's connected to but separate from the marketplace. So we do have more, I would say we have some interesting opportunities within health insurance here in New York State. And at the same time, one of the biggest changes that could have happened would be to allow for enrollment in health insurance for people who are undocumented, which California did 2 years ago and which we still have yet to do in New York State. So there's still more, there's tons more work to be done. And health insurance, of course, is still just the first step, right? Then you talk about like, what about kidney transplants for undocumented people? What about, all of these other kind of advanced therapies in particular? And I think, yeah, the list goes on. It's very challenging. But I would say the increase so there was an increase in eligibility for health insurance for undocumented people over the age of 65 in New York State. So that's a step towards what I'm talking about, but we're not there yet. Yeah, small step.
Let's cite